Welcome to Holistic Health for Happy Kids, the podcast where we dive into the root causes of children's health challenges and explore natural solutions to help little ones thrive. I'm Lisa, a passionate paediatric naturopath and mum of 3, dedicated to empowering parents with practical tips and expert insights to raise healthy, happy kids. Each episode will unpack common childhood health concerns like allergies, eczema, fussy eating, and gut health, and share evidence-based advice to support your child's wellness naturally. Let's create a generation of thriving children, one holistic step at a time. Thank you for joining me on this journey. Okay, so welcome to this episode of Holistic Health for Happy Kids. And today we're joined by Dr. Shereen Lim, who is a dentist who specialises in airway health and is also the author of this book, Breathe, Sleep and Thrive. So hello, and thank you for joining me on the podcast today.
Yeah, thanks very much for having me. I've been looking forward to it.
Great. So for people who are not familiar with your work, tell me a little bit about your story, what your qualifications are, and how you came to be so interested in this field of airway health and feeding and like oral function.
Yeah, well, I'm a general dentist. I qualified in 2000. And so around 16 years ago, 16 years ago, my husband's snoring was driving me pretty crazy. So I got out of bed one night in frustration and I started Googling about dental appliances that could help reposition the lower jaw during sleep to help alleviate snoring. And I decided I'm going to help other spouses in the same boat. And so I enrolled in Australia's first postgraduate diploma in dental sleep medicine. And so after doing that, I became involved in helping manage snoring and obstructive sleep apnea in adults, offering these appliances by referral from sleep physician. But as I started doing this, I started to recognize that snoring is actually really a symptom of a more serious condition called obstructive sleep apnea, where people stop breathing, and it actually is linked to increased risk of virtually every chronic health condition and impacts people's mood and their quality of life. And why are we doing this Band-Aid solution that compensates for poor jaw development? How come we don't grow jaws better in the first place? And so having done that qualification program, I came across Dr. Christian Guilleminot's work, a pioneer of obstructive sleep apnea and a pioneer in sleep medicine. And his research was finding that palate expansion in children could actually help with snoring and sleep apnea. And I wanted to know, how come we're not doing that? We're taught in dental school you can intervene to develop the jaws properly. But usually as a dentist, we refer to an orthodontist, and those children are getting told, let's just watch and wait. Every year they come back, watch and wait, and then around age 12, time to get braces. Often I was getting requests to take out the teeth, and I thought, it's got to be done better. I've got 2 children. I don't want them to have to go down that path of extraction of teeth. So that's when I learned about early interceptive orthodontics, how to develop the jaws in growing children with orthodontic appliances. But I also met Dr. Christian Guilleminot, who had inspired me to go down this path in 2014. And he said, if you're doing palate expansion, you're too late. So I actually really didn't know what that meant at the time. But basically, I now know form follows function. The jaws are growing most rapidly in the first 6 years of life. And the jaws, they're stimulated by the muscles. How the muscles are working will determine or influence how the jaw structures are growing. So if we can actually get the muscles, working as well as we can in the first few years of life, that will help promote a better trajectory of jaw development. And what this means is we need to pay attention to things like mouth breathing and nasal breathing. So nasal breathing is really important, looking at how the tongue is functioning and looking how we're feeding from breastfeeding onwards, how we're chewing, how we're using our muscles during breathing and sleep.
Yeah, it's really from day dot, isn't it?
Day dot, promoting nasal breathing.
And so what do you think is the biggest misconception that parents have about this whole area of mouth breathing?
I think the biggest misconception really is that it's not important. A lot of people probably don't realize or recognize how important nasal breathing is. You know, our nose is designed to warm, filter, and humidify the air before it goes into our body. And so when we use our nose, it also allows nitric oxide that's produced in our paranasal sinuses to be incorporated into it, and it's a vasodilator, so it promotes good oxygen exchange. It's very antimicrobial, so there's a lot of benefits in terms of nasal breathing, but really we want to pay special attention to it in early childhood because those light persistent forces of how the muscles rest during everyday breathing, that is the largest determinant of how the jaw structures are going to grow.
Mm. Yeah. And so I see an awful lot of kids who have sensory processing differences because I specialize in fussy eating, and lots of kids may have like sensory issues that contribute to their fussy eating. And when I read your book, it was very interesting because you made a link between mouth breathing and sensory processing. So how does mouth breathing affect a child's sensory processing and, nervous system regulation generally?
Yeah, I mean, so there is research to suggest that mouth breathing is linked to increased risk of sensory processing disorders, and there's been a multitude of mechanisms involved with it. But the ones that I'm particularly interested in is the mouth. It's really rich in sensory receptors. We get a lot of information from our lips, our tongue, our cheeks, and our mouth. And even it's about the same as our fingers. These are key areas where we get a lot of sensory input. So when we breathe through our mouth and have our tongue hanging low, it really alters that sensory input that we are supposed to be getting. So, for instance, one of the key areas in the mouth is the N spot where we put our tongue up. And when we say the letter N, it's just slightly behind our teeth. That is the highest concentration of sensory receptors. And so, for instance, we know when the tongue is not up there, it's not involved in proper neurostimulation. So when the tongue touches there, we know that it sends signals to the brain to release various neurotransmitters, including dopamine, serotonin, things that improve our balance, our sleep, our regulation. So that is one of the main areas that I'm most interested in. But there's many other mechanisms because if we have mouth breathing, we're going to have altered sleep, and that can affect our nervous system. It can put us in a state of chronic stress. And there's just various other things, how it alters our head posture and our vision and our balance. So there's many different reasons. But the one that I'm most focused on is just getting the mouth to sit where it's supposed to. The tongue up on that end spot, lips together, breathing through our nose.
When I was reading your book when I was on holidays over Christmas, and I was saying then to everybody in my family, "Where's your tongue right now? Where's your tongue?" It's in my mouth. No, where is it though? Is it resting on your roof? Is it down? Because it's so fascinating. I'm sure everybody who's listening to this is now fiddling around in their mouth with their tongue. And so yeah, go home and look at your kids and see where their tongue is resting. Because if it's not against their mouth, then they're not getting that stimulation.
Yeah, usually I find that children that are prone to things like thumb sucking or chewing objects or putting clothes and collars inside their mouth, nail biting, these are people that don't necessarily have that tongue on the end spot. So in myofunctional therapy, which is about retraining awareness of where the tongue is supposed to sit and getting the mouth working better, when people are taught to put their tongue on the spot, it's really interesting how many children and adults will say that they feel a sense of calm.
I could have done with that this morning because my electricity went out. I needed a sense of calm in my life.
Yeah.
Mm. So then any sort of sensory issues you can link to these sorts of tongue issues like sensory seeking, sensory avoidant, or is there a particularly sensory issues that you might see in those sorts of situations? Just general sensory dysregulation.
In general, if I see people that are having those habits, I usually do associate it with a lowered resting tongue posture. And where possible, we want to try to get that correct posture and the correct sensory input. But it's not always as simple as that. And sometimes these children are the ones that are more prone to, for instance, not really tolerating little myo spots or stickers that we would put to retrain where the tongue is. And so a lot of the time, uh, I love the Mayo Munchie. Have you heard of it? Yeah, the Mayo Munchie, that's usually a good starting point for me to introduce that sensory input and desensitize children's mouths, and just get the mouth working a little bit better. And then usually what I find is that when children can progress better with that, it's easier for them to accept or do other interventions.
Yeah. And then that will help them with different textures of foods and different tastes of foods and thing like that. So it was, I should have written down where it came from, but in the book you were talking about, red flags, I think about starting solids and things like gagging, food refusal, all of those sorts of things to do with mouth strength.
Yeah, I mean, really what I am trying to promote in terms of airway health is we want good jaw development, but even before good jaw development, we need good oral function because it's those muscles that stimulate the jaw. So in those earlier years of life, when the muscles uh, aren't working, we want to promote better use because that's when the jaw structures are growing the most rapidly. So I do say that myofunctional disorders where the mouth is not working correctly are the first warning signs that there's going to be problems ahead because this is going to affect the way that the airway grows and the way that it functions. So yes, chewing disorders or swallowing disorders, um, beyond that breastfeeding stage, they're going to be one of the key red flags that we need to be alert to. And so things that I would pay attention to is how well is a child chewing. Some children cannot chew and swallow properly. They may be more pouching of their foods, or they cannot manipulate their foods really well. So they're always moving their fingers inside their mouth to move things, or they may be spitting out foods after they've chewed them. Some children are quite picky eaters, so they won't really take meats or they'll be quite fussy with the foods. They won't want things that require too much chewing. They're some of the things that I look out for, or the red flags that tell me a child might not be chewing and swallowing as well without me actually having that opportunity to observe them.
And where do you sit with, purees versus baby-led weaning? What do you think is best there?
From a muscle perspective, it is better not to do too long with the purees and even the sippy pouches, because a lot of them promote the incorrect swallow where we're swallowing incorrectly. So for the first 6 months of life, the ideal way to optimize muscle function is to get optimal latch on the breast and getting that tongue working properly, and it moves the jaw back and forth and it stimulates palate development as well as forward development of the face. But from 6 months, when we introduce solids, if we can get that chewing action going, baby-led weaning can be a really good option to promote good chewing instead of overdoing that suck phase.
Yeah, because even puree off a spoon is still much better even than puree in a pouch because that's just drinking, isn't it? Whenever you're having puree from a pouch, you're just kind of sucking it and drinking it rather than there's no.
Yeah, you're overusing your cheeks to extract this food. And
Yeah.
so, yes, it's for convenience only. So we know anthropological research shows us that um, dental crowding, which is insufficient jaw development, is a fairly recent phenomenon over the last few hundred years, which is correlated with the introduction of more processed foods and pacifier use and these type of things which don't require chewing and as much effort of our jaw muscles.
Yeah. And then I think parents get into a vicious cycle because their kids don't learn to chew and therefore become stuck on pureed sort of textures.
Yes.
And it's very hard for parents to kind of get out of that because their children can't chew.
Yes.
It's just all very difficult, isn't it?
Yeah. So with industrialization and the processing of foods, we're not getting as much chewing action
Yeah.
going. So we need to practice that. If we're not getting that, that's where I think things like the Mayo Munchie, which is an appliance that children can use to put in their mouth and have chewing practice, that can be a really good way to promote good chewing, swallowing, closed mouth, nasal breathing, to as an added stimulus where children are missing out.
Yeah. I love it when you see pictures of babies in their high chair with like a little chop as well.
Yeah, yeah. Yeah, so that's where baby-led weaning is promoted as a way to introduce more normal function and going back to more pre-industrialized times as well.
So a term that I learned in your book that I'd never heard of before is nasal disuse.
Mhm.
Did you want to explain what nasal disuse is and why it's so important?
So nasal disuse refers to when there's the perception of stuffiness, congestion, often related to allergies, and then a child may be more prone to mouth breathing when there is not a true nasal obstruction. But then if we don't breathe through our nose, we're going to have increased congestion. So it kind of gets perpetuated. So there's a research paper, for instance, that studied a lot of children that had mouth breathing. And what they determined, I can't remember the precise percentage, but the majority or the major risk factor for mouth breathing in that sample was actually allergies. So not so much the blocked adenoids or the deviated septums, but this congestion, which is actually more reversible. And if we can promote nasal clearing and getting a clear nasal passage and then nasal breathing, it doesn't become a habit.
Hmm.
Yeah.
Because I had a client last week who they went to, I can't remember if they went to a doctor or dentist, but they basically just said your child's nasal breathing or mouth breathing is now just habitual. So that's basically what they meant was that they couldn't breathe through their nose because it was stuffy, but it's not stuffy, but now they're just not used to using it. It's pretty much what you mean.
Yeah. That's correct. So the ENT surgeon, Dr. Sarush Sagi, he published this paper where they actually tested children with lip tape for 3 minutes. Uh, so you can actually see how well they can breathe through their nose. And you could do this with a paddle pop stick or even getting a child to hold water in their mouth for 3 minutes to see how well can they breathe through their nose. And then what this paper validated was that if a child can breathe through their nose for 3 minutes, this is a child who may benefit from myofunctional therapy or trying to get them aware of this habit and try to promote more closed mouth nasal breathing before jumping into ENT surgery.
Hmm. That's a handy little test that everybody can do at home, especially with holding the water in the mouth. That's a good one.
Mm-hmm.
Kind of the opposite of, when you put on a scuba diving mask, it close off your nose, then you have to breathe through your mouth. I used to
Mm-hmm.
find that so terrifying for some reason.
Mm-hmm.
But I guess that was a good sign because it showed I was used to breathing through my nose.
Mm-hmm.
So tongue tie is a bit of a strangely controversial issue. I guess everybody has very strong feelings one way or the other. So tell me about, I guess the easy thing is tell me about tongue tie and then breastfeeding and how a breastfeeding mother might suspect that her child had a tongue tie.
So tongue tie refers to the attachment between the floor of the mouth and the undersurface of the tongue. And so if this is abnormally short or thick or restrictive, it doesn't allow the tongue to move properly. And a lot of the time, it may get looked at in hospital, but a pediatrician, for example, might say the tongue can poke forward, so there's no tongue tie. But the reality is what we really need the tongue to be doing is lifting. The tongue elevation or the mid-tongue elevation is really important for correct sucking, swallowing, breathing, and palate development. So it is really the elevation that is the most important. So therefore, if this connection or that attachment impacts normal elevation, that is a tongue tie. Yeah, and it doesn't necessarily need to go all the way to the tip of the tongue. It can be more hidden and still impact that normal elevation. And so for optimal breastfeeding, we need good tongue suction. So the tongue lifts to the roof of the mouth and it drops and it creates a vacuum, and that's when milk is efficiently transferred from the breast. So if a baby is breastfed with a tongue tie, it can play out in many different ways because even with a tongue tie, it's still possible to breastfeed, but there's compensation. So we may overuse other muscles, for instance, the muscles around the lips and cheeks to actually extract the milk without using the tongue. So that may not necessarily get picked up, but the child may not have any problems with milk extraction or weight gain or pain, but they're just overcompensating and using the wrong muscles. Other times it could look like poor milk supply because a baby is not able to transfer the milk effectively. Or there could also be pain due to the shallowness of the latch. Other times there may be poor swallowing and excessive intake of air. So there's clicking, and it may present as reflux-like symptoms or colic, where babies are very gassy, they're prone to spit ups and vomits, or they're very archy, stiff on feeding, needing to be held upright. And these children may get misdiagnosed with reflux and then require reflux medications, which don't actually seem to improve the situation. So there's quite a few presentations depending on how well a child is compensating. But at the end of the day, what we really wanted to promote is optimal latch, big, wide, open mouth, and good tongue suction to get the mouth working well. That's the foundation for good oral function, for chewing, speech, and sleep and breathing.
So, mums who have kind of gone on a very, very strict elimination diet and they're down to like 2 or 3 foods trying to resolve this reflux colicky baby, it really could be tongue tie.
Yes, I've seen that. It could be both, but definitely I think that if we have reflux-like symptoms, it's really important to seek consultation from a lactation consultant because it's really hard for us as parents to know what to look for. And in retrospect, I think one of my children that had these issues, I was not really able to recognize it. And it wasn't until I became involved in this area and one day I looked at one of her baby photos and I saw her tongue was covered in white milk. And I realized, wow, she wasn't able to suction her tongue, or else that tongue would have had that milk cleared. It wouldn't have accumulated on her tongue. So I always thought, wow, she's just a fast feeder, very efficient. She would be on and off because it was obviously quite tiring for her and more unsettled, needing to be held all the time. So I think that it's really important. There's a lot of value in all children having lactation consultant assessment. But lactation consultants do have variable knowledge in terms of tongue tie and oral function. Some will be okay if there's no pain, good weight gain. They may compensate with issues with a nipple shield. But really, we want to find someone that understands good oral function and really can understand how this can set up a child in the long run if we can promote that good function.
So, what can parents look for in a lactation consultant? Because I even see in like the mothers group pages where I live, people are obviously not getting the right experience with the lactation consultant. So, is there some sort of special qualification that they should have to know that they understand tongue ties?
Yeah, I mean, the highest qualification for a lactation consultant is international board certified one, and they have done a lot of extra training. They've had to pass some examinations, but even then, there's a lot of variation in their knowledge of tongue ties. So I'd be really looking for someone who has demonstrated that they've done extra CE or continuing education on this, who actually works in collaboration with a tongue tie provider, a release provider. They will know a little bit more about how to work with chiropractics or manual therapy, osteopathy, to really understand that tongue tie is not an isolated problem. It actually impacts the way that the muscles and the body work as well. So I would be looking for someone that has a proven record that they've been involved in the integrative team management of these issues.
Yeah. So so I've been a migraine sufferer for 30 odd years now. And something that I had never considered until I read your book was the connection between some sort of jaw, airway, tongue issue and my migraines. Tell me what the connection is between migraines and all of these issues.
Yeah. So when the tongue doesn't work well, when it's restricted, we usually have to use other muscles to compensate. And sometimes that will mean to get the tongue lifting, we have to use our jaw and our neck muscles. And so that chronic overuse can lead to trigger points inside those muscles, which then refer pain into the head region as well. And so sometimes people that have these headaches or migraines will get a sense that they actually originate from their neck. And if I watch them lifting their tongue and there's a lot of overuse of the neck, that might be a patient that I will perceive that if we can get the tongue working better, possibly with a release, that they will have alleviations of their headaches and their migraines. So I haven't actually had a migraine patient for a while, but very commonly when we do the tongue tie release and we can get this tongue working stronger and not having to use this compensation and offering that release, we can get a lot of alleviation of headaches. And sometimes I'll find that there'll be some patients that will get alleviation of these headaches, but they may occasionally have that monthly migraine. So, but it really improves their quality of life. And so I think if there's any of these migraines or headaches, it's worthwhile seeing a myofunctional therapist and just assessing how well is that tongue working and trying to get a sense of whether that is originating from the neck, with the root cause being the restriction of the tongue mobility.
Yeah, it's so interesting, isn't it? Because I would never have thought. And then what about teeth grinding? Does that kind of, is that a completely separate issue or is that to do with the tongue restriction as well?
Yeah, teeth grinding is, especially in children, it's been identified as one of the strongest red flags that a child is not breathing well. Maybe not the only reason, but in dental school, we're not taught this. We're taught it's something that children will outgrow. But teeth grinding is thought to be a protective mechanism when there is a restriction in airflow. So when we're asleep, say the tongue hasn't been working very well, we really need the tongue resting up in the roof of the mouth. That good tone, it helps to keep the throat open. But when we're asleep and everything's floppy and more relaxed and we're lying on our back and that tongue's not sitting well, it's more likely to obstruct inside the throat. So for an adult, they may have obstructive sleep apnea, which is more prolonged obstruction or blockage of airflow. But in children, when their fight or flight or sympathetic nervous system is more working or intact, there'll be a stress response and an arousal from sleep, and that will be accompanied by the grinding, which actually moves the lower jaw back and forth to open up the airway. And that protects a child from getting the apnea. But it's still quite interruptive. They may not get oxygen deprivation, but when we have that episode, it actually interrupts sleep. And so a child may not be able to enter into more deep sleep. And that means that sleep is unrestorative. We don't get the full restorative benefits of sleep. And a child may present with those, behavioral concerns or difficulties with their emotional regulation. So when we have a child who is teeth grinding, we need to think, how well are they breathing? Are they breathing through their nose? And where is their tongue? So anytime a child is teeth grinding, we want to just check, what is that tongue mobility like? And yes, I believe that we should be doing that in adults, because normally when we can get a child breathing better, there's actually significant alleviation of teeth grinding quite often. And it's not just getting the tongue to work better through tongue tie release and myofunctional therapy. The research tells us that even when children have adenoids and tonsils removed, 2/3 of children may have alleviation of teeth grinding. Or what I do a lot of is widening the palates in children, expanding the palates. And many children will actually stop grinding with that opening of the palate. And I think it makes more room for the tongue to sit properly as well. So it's not just tongue tie, It's a key red flag that a child might not be breathing well, which could be a multifactorial problem related to, is there any blockage of the airway? What is the outer borders of the jaws structures looking like, the outer borders of the airway? Or how are those muscles working and where is that tongue sitting?
I have a weird question, and I'm not sure you'll be able to answer it, but we see a big correlation between teeth grinding and thread worms.
Yes.
We treat the worms, the teeth grinding goes. Why would that be? I always just think, oh, it's just the child's kind of irritated in their sleep because they're scratchy, so they're kind of just stress grinding. Do you have any other ideas of why that might be?
No, I mean, well, as a dentist, that's what our focus is on. So I
Yeah.
haven't had a lot of experience regarding that. Um, but yeah,
Yeah, I don't know. It definitely seems to be important, but I'm not sure why.
yeah.
Um, so what else have we not talked about that you're very passionate about or you talk about in your book you would like parents to know about?
I think really recognizing that nasal breathing or airway health, which is good nasal breathing 24/7, day and night, good jaw and airway development, and good orofacial muscle function. They're really the keys to thriving health and vitality. And it's not really recognized. All these problems with obstructive sleep apnea that we're seeing in adults, they're a developmental problem with their origins from infancy and how well we're using our mouth and how well our jaw structures are growing. So to be able to really recognize one of the most important things that we can do is establish nasal breathing early. And when it comes to nasal breathing, it's not just about seeing an ear, nose, and throat specialist to check inside the nose. We really need to recognize that the jaw structures are really important. So the upper jaw is really the floor of the nose, like our nose sits inside the upper jaw. So there's a structural component of that nose that comes from that jaw. So beyond seeing an ENT surgeon, or even if a child has had any ENT surgery, such as removal of adenoids and tonsils, many of those children will have a recurrence of those issues later on because that's not a complete treatment. We have to develop the jaw structures really well. And even after we've opened up the airway through taking things out with ENT surgery and remodeling the airway through orthodontic treatment, we still have to correct the habits, promoting that tongue up and closed lips. And many problems that children are having, whether it be the sensory processing or the speech, chewing difficulties, bedwetting, ADHD type symptoms, they may actually really have their roots in poor breathing. And so if we can establish nasal breathing, it's really going to be better for our muscles, for all the other functions, and our even our dental health as well. When we can have nasal breathing, we're not going to have the dry mouth and the increased risk of dental disease. So recognizing that importance of nasal breathing and the structural contribution of the jaws as well, that the dentist has an important role to develop that and promote nasal breathing.
It's funny because you said about, with your child and you look back now and you realize that there's an issue, but you didn't at the time. One of my children had very strong ADHD behaviors and got lots of cavities, even though she was on a really good diet. She used to have extra pillows and actually prop herself up into kind of a 30-degree tilt to
Mhm.
sleep, which was clearly because she couldn't breathe when she was lying flat, but I didn't realize. She was sweaty. She would sleepwalk. She had night terrors. She wet the bed. She literally ticked every single box for sleep disordered breathing. But when I look back on photos, and I've gone back through my photos over and over and over again, her mouth is closed. So could she have had a problem but had her mouth closed, or am I just barking up the wrong tree?
I think we want nasal breathing day and night.
Hmm.
And so the symptoms, like you said, parents should recognize when there could be symptoms of sleep disturbed breathing. And really, we want children to breathe through their nose 90% of the night or more. And so when we watch children sleep at night, like I did this when my children were young, quite often they'll have their nose, they'll be breathing through their nose with their mouth closed. But it is quite possible that at other points of the night, particularly the later half of the night where the mouth is more relaxed, the muscles are more relaxed, there may be more mouth breathing. So we don't really 100% know if they're actually breathing through their nose the whole night. But the red flags that we need to look out for, really, when a child is sleeping, we want them to have their lips closed and be silent and still. They should look restful, not thrashing, tossing, turning. There shouldn't be any real sweating or drooling, bedwetting, teeth grinding. Children that toss and turn, lie on their stomach, have their neck cranked back, or they wake up for no apparent reason. They may come into their parents' room in the middle of the night. They're the children that we must ask, how are they breathing? What is actually waking them up? Could it be a breathing interruption? And then that's when we need to pay closer attention. And a dentist who has a special interest in airway, they may be a really good person to screen for red flags, because a lot of the red flags of issues are actually inside the mouth. If there is any dental crowding, the jaws aren't growing well. If there is a tongue tie, which is associated with low tongue posture. If there's any enlarged tonsils, a dentist can be a really good person to look for that. So I think that it is really important for a parent, firstly, to recognize what are the symptoms to look for. And then if there is anything that is not quite right, yes, speak to someone else to see if they can help identify the risk factors. And before medicating children for conditions like ADHD or insomnia, difficulties sleeping, a lot of kids getting the melatonin, where they may not feel that sleep is restful. There may be a subconscious fear of getting to sleep because it is quite interrupted. We should really check out that sleep and breathing more closely.
Yeah, absolutely. I'm picking myself.
We all do.
I didn't realize it at the time,
Yeah.
but it makes me a better practitioner now when I realize where I went wrong. So thank you so much for joining me today. So I'll just grab the book. So for anyone watching the video, this is the book, Breathe, Sleep, Thrive by Dr. Shereen. And it's a great read. It covers everything that we've talked about today. And basically, in my opinion, every single child should now have some sort of investigation into this, because, everybody is having issues with anxiety, ADHD, like everybody sort of has some issues that could be related. So best just to get it checked out. So thank you so much, Shereen.
Yeah, no, thanks so much, Lisa. This is a really important area, promoting nasal breathing for children. And most of us health professionals do not get enough awareness or training in this area. So it's fantastic that you, as a naturopath, can really help screen for these children and have a bit more knowledge to be able to refer and help parents, because a lot of families are struggling with these issues. So I really appreciate what you're doing as well.
Absolutely.
Yeah.
Thank you.
Thanks for tuning in to Holistic Health for Happy Kids. I hope you found today's episode helpful and inspiring on your journey to raise thriving, healthy little ones. Remember, small, consistent changes can lead to big transformations. If you enjoyed this episode, please subscribe, leave a review, and share it with other parents who might benefit. You can also follow me on Instagram and Facebook at the Paediatric Naturopath for more tips, tools, and inspiration. If you've got a question or a topic you'd love to hear about, please send me a message. I'd love to hear from you. Until next time, take care and keep supporting your kids in the most natural, nurturing ways possible.